Welcome to Appalachian Wellness for a new tomorrow and a new you. I'm Raymond Owenbrink, the president and owner of Appalachian Wellness, where we specialize in you. Today, we're going to talk about the summarized treatment of the chronic inflammatory response syndrome. This pyramid illustrates how the treatment of CIRS works. At the base of the pyramid, you see the largest number of people. Most people, especially children, seem to get better when they're removed from the ongoing toxic mold or toxin exposure. A smaller number of people will need to be treated with toxin bindings, such as cholestyramine or closevital, which is known as Welchol. The next step is to eradicate multi-drug resistant coagulase-negative Staph aureus that forms biofilms in the sinuses. This is generally cultured for at the very first visit, and if this is present, it must be eradicated because it splits MSH to its predecessors and continues the inflammatory process. Anti-gliadin antibodies must be sought and corrected. These are antibodies to the wheat protein, so they will need to be on a gluten-free diet. Many people, especially children, will have transient gliadin sensitivity, and after 90 days of abstinence, no wheat, they will revert back to normal. After 90 days, it's okay, some people say 1 month, to reinstitute the gluten antibodies, gliadin intake into the diet, and they'll do okay after that, especially once these other steps that precede it have been treated. Men may have low androgen testosterone levels, so we have to normalize those. We have to also correct ADH, antidiuretic hormone, and osmolality, which has to do with the number of salts that are in the bloodstream. Matrix metalloproteinase 9, it's a mouthful, has to be corrected. VEGF, vascular endothelial growth factor. C4A is part of the complement system. Finally, there's transforming growth factor beta 1, which transforms normal cells into basically scar tissue formers or fibroblasts. The final step will be needed by the smallest number of people, and that's use of nasal vasoactive intestinal peptide spray, which works incredibly well, but does not work if we haven't corrected the preceding steps. So I cannot emphasize enough how important it is to correct those earlier steps before starting the BIP. The most essential point of treatment: remove from exposure. If exposure is ongoing, there's no chance of getting better from SIRS. Cholestyramine is given for 30 or more days. If there's any low-level exposure going on, continue the cholestyramine indefinitely as needed to bind the toxins that are being absorbed. Now, these toxins can come in through the air, through your diet. They can, even with a mask on, they can bind to the tear film in your eyeballs and be absorbed. These things can be very, very hard to get rid of. The cholestyramine and Welchol, the way they work, the liver secretes bile into your duodenum, part of your small intestine, when you eat a meal. The gallbladder squirts it out. If you don't have a gallbladder, the liver is continuously dripping a little bit of bile into your gut. That bile contains these toxins. The bile is reabsorbed in the distal part, the last part of the small intestine before it becomes the large intestine. That's called the ileum. Once the bile is reabsorbed, it goes back to the liver. It's recycled and used again. These bile salts, bile binding resins, grab hold of the bile so they're excreted in the stool, taking the toxins with them, which is a good thing. Cholestyramine will reduce C3A and C4A elevations. C3A is found where membranes are present, such as Lyme disease or Borrelia, Bartonella, Babesia. C4A is found with any other biotoxins. So we have to get these levels down to know that we're making progress in treating the SIRS. And we will check those at the initial visit, and then we'll check them periodically as we go along. We have to eradicate the biofilm formers. MARCONS is an acronym. It stands for Multiple Antibiotic Resistant Coagulase Negative Staph. The staph actually grows in a biofilm, think of it as a slime, that's within your nasal sinuses. not in the nose itself, but deeper than that in the sinuses. We have to get rid of that if it's in there. It has to be cultured very specifically. A standard nasal culture won't do it. We have to look for an API-staph culture done by a specific lab known as Microbiology DX. The next step is looking for gluten sensitivity. We have to check for anti-gliadin antibodies, AGA. If they're positive, we have to avoid any type of wheat in the diet for at least 30 days. Some people will say 90 days. Then we can re-challenge at that point. If the antibodies become positive again, we'll do a tissue transglutaminase assay, which is a more sensitive test. It will also look at the gluten IgA, IgG, and IgM antibodies. We'll expect to find more of IgG than IgM, but it's good to measure all three. We have to normalize the decreased androgen levels. A look at estradiol testosterone ratios will help determine if the aromatase enzyme is upregulated. We'll get into more of that in the future here. DHE sulfate, DHEA sulfate, stands for dihydroepiandrosterone sulfate. And that's a precursor to all of the steroid hormones. We can give extra DHEA by mouth initially to correct the upstream formation of androgens, but the aromatase inhibitors will continue to swap that androgen into estrogen. Okay, as we get better as far as the SIRS treatment is concerned, that process will cease. ADH stands for antidiuretic hormone. That and osmolality, which stands for the amount of salts in the blood, dissolved in the bloodstream, these two tend to follow each other. A high ADH should be linked with a high osmolality. SIRS causes dysregulation of this, so the ADH may be high with a low osmolality. We have to look for this, and if it's present, we have to correct this, and we have ways we can do this with medications. DDAVP is one of these medications. It's used as a nasal spray, and we'll get into that more in the future. We have to look at the matrix metalloproteinase 9 levels. If those are elevated, we have to fix that. Omega-3 fatty acids are supplemented. We check a leptin level. This has to do with fat storage. If the leptin level is below 7, omega-3 fatty acids work pretty well. 2 grams of basically fish oil twice a day for a total of 4 grams a day does a pretty good job of correcting the MMP9 elevations. If the leptin is above 7, however, we use a medicine called Actos, which is used to treat diabetes. It's a TZD class, and we usually don't use it for as long a term as a diabetic would use it. We just use it for a period of weeks or months to correct the MMP9. And once the MMP9 normalizes, we can discontinue the Actos and monitor the MMP9 levels and make sure they don't rise again. We have to look for the VEGF, vascular endothelial growth factor. VIP is the safest way to increase the VEGF level. VEGF is actually used, that whole concept is used in treating cancer. It causes the formation of new blood vessels. So if we can stop new blood vessels from forming in a tumor, that's a good thing. But it also contributes to the CIRS problem. Chronic fatigue is present because there's not enough oxygen reaching the mitochondria in specific tissues. Brain fog, same situation. The VEGF is low, so we need to get that sucker up there. Vasoactive intestinal peptide works very well. That's the safest way to do that. There are some cautions with it. You have to check a lipase level. That's a pancreatic enzyme, which can go up with use of VIP, so we have to monitor that. So before we start the VIP, we have to check the lipase, the TGF-beta1, C4a, and VEGF initially and then quarterly. And there is a specific protocol that we use when we start treating with lipase. While somebody's taking lipase, we have to check their lipase. While they're taking VIP, we check their lipase levels monthly. Erythropoietin is a more risky treatment. There's more side effects and risk for problems. This is an off-label use of this medication. We have a specific protocol. Again, we check the baseline TGF-B1 because that's really the biggest thing that VIP works on. And the C4a. This time we also check, however, a D-dimer and a CBC. D-dimer can go up with blood clots, such as in the legs or in the blood clots in the lungs. And the CBC, we want to make sure if the hemoglobin goes above 16.5, it's too high. The FDA does not want that hemoglobin above 10 if we're treating somebody with erythropoietin. We have to also ensure that informed consent is signed because this is a risky drug, and it's a good idea to record the lot number of the erythropoietin that's used because there have been recalls in the past. We have to lower elevations of C4A and C3A, avoiding further toxin exposure. Again, that's the very first and foremost thing that we have to do. Erythropoietin will help that. Okay, we have to lower the elevations of TGF-beta 1. Losartan, 12.5 milligrams daily. Losartan is a blood pressure medication. So we start with losartan. We give it twice daily. Okay, we can start at 12.5 milligrams and try to increase it to 25, and then maybe all the way up to 50 as the blood pressure will tolerate it. If you get dizzy when you stand up too fast, that's an indication that you're taking too much losartan and we have to back off on the dose a bit. VIP therapy also works very well for this, and it's safer than erythropoietin. And of course, we can consider use of erythropoietin as well. We start the VIP per the protocol. And again, don't kill the golden goose. This stuff works magic when it's used appropriately. There are some guidelines we have to follow. The Environmental Relative Moldiness Index, ERMI, looks at all the different toxic mold that may be present in your environment. And there are some parameters to use. HERTSMI looks at mainly just the mold that are known to cause problems. It doesn't look at all of them, just the ones that are most likely to be causing problems. It's a less expensive test, and it works about as well. We check the MSH level. The MSH level, if it's less than 20,000 and the ERMI is less than or equal to 2 and the HERTSMI is less than 10, it's okay to use the MSH. I'm sorry, the VIP. If the MSH is greater than 20,000, we don't want to start the VIP until the ERMI is less than 1, excuse me, and HERTSMI has to also be less than 10. We take 2 puffs in the nose 4 times a day. VIP comes in a little regulated nasal spray bottle. It needs to be kept refrigerated. It's about $200 a month for the treatment. It's fairly expensive, but it does an incredible job. Again, we initially check the lipase, TGF, B1, C4A, VEGF. We also check the blood pressure before we give that initial dose too. We check all these things initially and then quarterly, and of course the monthly lipase levels.